AM 1220 KHTS, hometownstation.com. I am T. I'm here today with the Providence Holy Cross Hour talking to Dr. Bob Raji, who's the Chief Medical Officer over at Providence Holy Cross, one of the most Excalibur facilities if you have to go to the hospital. I'm quite the fan of Providence Holy Cross. Dr. Raji, we were talking about various aspects of Providence Holy Cross and things, the challenges, and I want to talk a little bit about something that's on my paper. You're going to have to educate me. In addition to patient satisfaction initiatives, HRO, which stands for
High Reliability Organization, and let me expound on that and explain it. As you know, Holy Cross is involved with the Providence Health System. 39 plus or minus hospitals from Alaska down to Southern California. And the system has committed to a high reliability organization journey. And what that means is it started out by the Department of Defense, adopted by the Atomic Energy Commission, and they look at the misses in product delivery. So they want to achieve the zero. So there was a study by the organization Mendelson that the amount of deaths from medical errors that happen in the United States is equivalent to one 747 crashing every day. So they look at all the
from mistakes
from medical errors across the country. So they felt that hospitals were behind the other industries, Department of Defense, Atomic Energy. So we've engaged on a journey to become a high reliability organization, to have mistakes approach zero. And we have a system, an algorithm that we look at the various problems that happen with patients. A lot of time patients go home and don't take the right medication and then come back to the emergency room. So we're looking at every possibility, and we've just begun this journey a couple of months ago, and it's not the flavor of the month. It's something that we will continue to do and become more and more safe. And I don't think there's a lot of hospital systems involved in that in Southern California other than the Providence brand.
It is amazing to think that an error, and for so many reasons, it's not that I think, again, it's that checks and balances where your accountability and one to another and communication, and that has to be very challenging, too, to figure out where the cracks might be to fix that. That's incredible.
One of the benefits that we have, you mentioned off air, living in this time, is technology is booming right now. So we have the other challenge that we're having is the electronic medical record. And it's evolving into the electronic health record that will be shared from one hospital to another hospital. We have a pilot program with our emergency system looking at other information from other emergency rooms where the patient has been to a patient where it's got medication and treatment, and they are looking at the information if the patient was a month in another ED. So information is booming for the physician, and now we have to look at how we can use that to improve care and improve safety.
Oh, it is wonderful how technology on so many levels is helping. My maternal unit has atrial fib. She has some heart issues, and on her phone she has a device that she puts her thumbs on it, and it sends a record of what her heart is doing directly to her doctor's office. And I think to myself, 20 years ago, that would have been science fiction. And the idea that the more we learn, the more we do, the more we implement the things that are available. Again, it's the I can't believe we have an app for that.
There's more to come.
Well, tell me a little bit then how you see things changing for future for hospitals and physicians. And in addition to this high reliability organization, I think that's so critically important for not just your job and for the patients, but for the patients to come. What else do you see changing for hospitals?
Well, as we've spoken about, there is a change in medical care reimbursement that is affecting change. There's something called the pay for performance, so that the hospitals across the country will get penalized if they have a high infection rate or if they have a lot of hospital-acquired conditions in the hospital. There is a metric that they will be looked at, a certain diagnosis, AFib or cardiology, MI, that the patient should be in the hospital for 3 or 4 days, and the government will pay for a certain amount of that, but not over that. The government is looking at their federal budget, and medicine is a huge amount.
You know, the idea that technology, the data collection, in and of itself, something that I don't think hospitals before, when things were manual and things were analog, but the idea that digitally now you have these programs that can crunch the numbers and the information and do more than a human being ever could have is really a mind-blowing thought process, that now the accountability completely changes because here's the information, here's the data, this is how it is. And I could see why Providence Holy Cross has that the eye on the prize, not just for patient care and for high standards, but the idea that this is just the wave of the future. This is the way it has to be. And again, I do hope, Dr. Raji, that you guys are the model for just about every other hospital the nation has to offer. How about for physicians in particular? I know that we talked about you guys being slammed with just simply the body count having gone from 80,000 to hundreds of thousands of people. How does this affect their job? What do you see the future for them? How is it changing?
The physicians are malleable. They're working with the change. They're coming up with new ideas and new systems. And the nice thing about it is the senior leadership isn't the one bringing up all the ideas. We engage all the physicians to give us ideas. What are the improvements that we could do? That's part of the magnet nurses to have their voice heard. We have regular meetings with the doctors. We do not make decisions without their input. So they are engaged and they are giving us ideas. I think the challenge is we have so much information. We have to spend our time deciding which information is the one that's going to give a clinically better product or a better outcome. We have something that I didn't have when I trained. We have ventilators that are giving the ventilator settings and the pressures and the volumes directly into the computer. Computerized medical record. We have anesthesia machines that are delivering information into the medical record, so we can look at it. And the question is, what is the data that you want to make improvements on, any field of medicine you can think of. We talked about the telestroke. Telemedicine is big across the country, and it probably will get bigger. There is a shortage of physicians still. There is a shortage of primary care physicians. There has been physicians extenders, which I've worked with and I'm very pleased with. Many surgeons have physician assistants, which help them as a right-hand person to the surgeon, and there are nurse practitioners who function in the primary care role. So this is something that we need to help as our population increases and we have an aging population. But telestroke isn't the only telemedicine they have. They have telepsychiatry we have in the emergency room now, so that we can evaluate a patient with the psychiatrist on the telemodule. There are places where you have telemedicine in the ICU. With our intensivist program, we are looking at that model to have a physician available to evaluate the patient quicker. And Providence has a system that they're going to roll out to their hospitals soon, a teleconsult. So if you want to talk to a nurse practitioner, you can get on it. The price is very affordable. I think I heard mention of $39. You get on your video and you talk to a patient, and that's something that's coming forward.
It's so futuristic, and I believe it's something whose time has come, because so much about medicine is observation. I have to think at some point there will be a camera on your patient where every little, shudder or tick or everything that's being uploaded into a system will be able to help you, if you weren't there to observe your patient, to come in and say, well, here's what was observed in the last 2 hours, 4 hours. What a time, again, what a time to be alive. As a doctor, where you are now as Chief Medical Officer at Providence Holy Cross, Dr. Raji, do you look at this and think, gosh, does it ever make you wish to be to have more time, to have more hours, to have more years, because it is so exciting to be at the cusp of what tomorrow's medicine will be. How is that for you? Because you came from this place, we were talking about anesthesiology, and I know you come from a place of compassion and concern for the patient, because that is one of the most important things you can do for a patient, alleviate their pain. But as a doctor now, do you look at where you were, where you've come, where you are, and what is coming down the pike? How does that feel for you?
I think every physician went to medical school out of compassion and empathy to help the human condition. And I think every physician is thinking like I am, that we are in the middle of a tremendous change. A lot of it is technological. A lot of it is the way we pay for medicine, the way the medical model is from Washington. But the technology, it just boggles my mind. We have one of the best robotics system in the robotic surgery, and there are certain surgeries that are very technically difficult to do in the old technology, but the robotics make it a lot easier. They have less tissue trauma, improved outcomes, and improved discharge from the hospital. There's a tremendous amount of technology helping that, and if you look at your iPhone, look at where that has gone in 10 years, and it's not done yet. Things get smaller and smaller. Apollo 13 had a computer that was had less memory than the desktop that you have over there, or the portable. I think one of the big things that are happening in medicine is biotechnology and the advances in mapping the human genome. You'll hear terms like systems medicine or personalized medicine. There are certain diseases that your genetics are having you prone to develop, and there are different ways of treating them. They're working on different blood tests to diagnose whether you have certain cancers, and then the challenge is finding out where that cancer is, finding it in a very small size, as opposed to a very large size in the older technology. And then we move into the technology changes with radiology, the eyes of medicine, and the state-of-the-art MRI and the CAT scan. So you'll be hearing more about genetic medicine with our cancer program and with our Providence research. One other fascinating technology is we have a pill-sized camera that we swallow. So instead of getting a full colonoscopy, you swallow it, and it does. It sends a signal.
Is the prep time easier?
The prep time is fantastic. It's fantastic.
Because the old one is not working for me.
It's not fun.
So if I don't have to go through that and then swallow the camera, I'm totally fine with this.
That's right.
Yay, this is good.
As long as you don't aspirate and end back in the ER.
We're all good.
Learn to chew.
Yes, that's critically important. If you, in your catbird seat of where you are, because I know you must have the articles, you must see the information that comes in. Are there any things that are now still a little bit science fiction that you look at and think, oh, that is the one or two things that I really hope come to pass in my lifetime? Or is there anything out there that you've heard about or that you see that's possibly on the horizon, or you would like to see?
Well, as I said, the technology of diagnosing different things are progressing and will continue to progress, and that's a good thing. Our population is aging, so geriatric medicine is becoming, people are living longer and longer, and we want to make sure that the quality of life is better and better. Preventative care and wellness is very important, and I see that genetic medicine is very important. If I could take a blood test and tell you which cancer you're going to develop, and there are certain environmental triggers, there are certain dietetic triggers, pollution that could start it, and they are working on drugs that will turn on or off the certain gene that would cause that. So I think there's a real tremendous future.
If you could give patients advice, listening and thinking to themselves, well, I love Providence Holy Cross, and if I don't have to go too often and I can lessen your numbers a little bit, what are a couple of the bits of advice you'd give them that they should, like the things they could, the simplest things they could do as preventative right now that they could
wash your hands often before each meal, sing a verse of happy birthday and wash your hands.
That's right, that's the time frame, right?
Happy
birthday.
And eat well and exercise. It's not rocket scientist.
We've all become pretty sedentary. The world has been created so that we sit at a desk, sit at a computer, sit at a television, sit on a bench, look at our phone. I mean, for the most part, motion has been taken out of the equation of the human condition. So even just walking, just getting out there,
right.
And do you have when you see patients when they come in to Providence now, because you have you have these huge numbers, do you sometimes think to yourself, I wish we could get patients before they come in and let them know that the hospital isn't the first stop?
Well, we're working on some community outreach and educated the patient. I mentioned hand washing. It's the simplest way to decrease infection and to contagious diseases, and it really is important. You've seen the studies. You go into a hotel room, the TV remote is one of the dirtiest things that you're going to have. A community used computer has little bugs on it. So hand washing is tremendous. Diet is important. People need to be educated about that. Vitamin supplements and exercise is very important.
And then you see a huge boon, I would imagine, the doors burst open during flu season.
It's coming. Yes, we're going to start our flu vaccine campaign very soon.
I told you I haven't had a flu shot, and it's time. Isn't it? It's time.
It's recommended.
It's recommended.
It is recommended.
Because even if the flu vaccine isn't, I mean, it's better to have something, an umbrella if it does or doesn't rain. And I think a lot of people, that's one of the fears. But you see a lot of people at the ER that come in with terrible, terrible flu symptoms.
You know, I'm a history buff, and I think it was the flu epidemic of 1918. Tremendous, many people, and it was an epidemic. It wasn't a pandemic. It was huge. Across the world died. That flu was directly related to the increase of Parkinson's disease. So flu is a deadly virus and can affect us. And we don't have any antibiotics that can treat viruses. The only thing we can do is prevent them.
So between natural disasters and flu season, I have to believe you would really like to, for the most part, keep people to where they can take care of themselves. And flu is one of the things that they can do, just like you say, washing your hands, getting getting
preventative
the flu.
Medicine,
preventative medicine helps
colonoscopy checks, mammography, and take care of yourself.
And when it all comes down to brass tacks, at the end of the day, us helping ourselves helps you at Providence Holy Cross so that you can deal with the bigger issues. And I know I talked to some doctors before about the Affordable Care Act, how some people will come to the hospital for, the things that they could just be taking care of on their own. Dr. Raji, again, I'm a big fan of Providence Holy Cross. I think it's all of your staff. Everyone does an amazing job, and having had a chance to speak with you today, I think it is the trickle-down theory. I think it comes from the top. So as Chief Medical Officer, and the idea that you are overseeing an awful lot of people in an awful lot of departments, I'm very grateful to have you come in and talk to us a little bit about today, Providence Holy Cross. I look forward to hearing more about what is happening at Providence Holy Cross, and when we come back, we'll talk about how people can learn more about what is going on over Providence Holy Cross via the internet and the community outreach. Stay with me. You're listening to the Providence Holy Cross Hour here on your hometown station, AM 1220, KHTS. Again, I'm here with Dr. Bob Raji, who's the Chief Medical Officer. We'll be back in just a minute. AM 1220, KHTS, hometownstation.com. I am T here with the Providence Holy Cross Hour, talking to Chief Medical Officer Dr. Bob Raji. We've been talking an awful lot about what is happening over at Providence Holy Cross, how there are so many efforts being made to improve patient care and the high quality care that Providence Holy Cross offers. Dr. Raji, I have a question about you. How did you come to medicine? Did you just wake up one day when you were a little kid, when they asked you that question, what do you want to be when you grow up, and you went, cowboy, wait, no, doctor? How did you come to decide you wanted to?
I'm a jokester. I'll tell you the joke. I was in the seminary, and I joke and call it the cemetery, and I was studying philosophy. I got very interested in psychology and then psychiatry, and that's how I get into medicine, with an interest in philosophy, psychology, psychiatry, and I'm not too sure where anesthesia came involved in that.
Somebody in your family must have been a real people person, because you have to really like people, and I know an awful lot of people who don't like people, and they don't come to medicine no matter how interested they are in philosophy or psychology. They just want to get as far away as they can from anything having to do with that. Was there...
My father was a very social person.
Was he? So there were people, and he cared about people, so there must have been great empathy. So when you started in medical school, because I know one of the things we talked about in our hour is there's a shortage of physicians.
Correct.
And we want to bring more young people to science and medicine. What was, a twofold question, what was the thing that was most interesting and came easiest, you think? And what was the thing you really had to bend over backwards and apply yourself to get through, because it wasn't as easy?
Medical school is divided into didactic for the first 2 years, and then clinical for the second 2 years. So the reason people go into medicine is the second 2 years. They enjoy the people, the patient contact, and they felt like they were just being more effective in helping people rather than book learning. Mm-hmm. So that's the hurdle. My son's in medical school now, and he loves it. And it's very challenging for medical students now because of the amount of debt that they get into, because of the debt from college, and then they carry over to medical school. So that is a burden, and young physicians face that.
That might be a conversation for another time, how we're going to fix that.
Right.
Because if we do have a shortage, and I do worry personally, I'm a native Californian. I've been through our 4 seasons, flood, mud, fire, and earthquake, and I know that it is critically important to have trained people on the ground in the time, and it's not a matter of if, it's a matter of when, and the idea that even our hospitals are going to be, short supplied. That would be nice if that wasn't one of the hurdles these young people had to get over.
Well, the physician does reward with various financial incentives doctors who go into primary care.
Oh, Dr. Raji, thank you again, speaking to us from Providence Holy Cross, the Chief Medical Officer there. Very, very happy to hear about you, Providence Holy Cross. If you'd like to learn more, you can go to providence.org.